Good evening and welcome to our educational webinar on Lapiplasty 3D Bunion Correction. We appreciate you joining us. I'm Kendall Rock, Social Media Specialist at Treece Medical Concepts. Treece Medical Concepts is the company who patented the Lapiplasty procedure and manufactures its instrumentation and implants. Our goal here tonight is to provide you with quality information because we know that making a surgical decision is a decision that isn't taken lightly. We applaud you for empowering yourselves with information to make the best informed treatment decision you can. I will quickly get a couple of housekeeping items out of the way so we can get right into the presentation by our surgeon speaker, Dr. Jordan Cito of Mesa, Arizona. First of all, you are all listening on the webinar on mute, but you can ask questions throughout by clicking on the questions tab in your control bar and typing them in. We'll be answering questions sprinkled throughout the presentation and at its end. We will also be emailing you an archived link of this presentation to refer back to within just a few days. Lastly, I know that you will enjoy our speaker, Dr. Cito, but if you are attending outside of the physician state, you can find locally trained Lapiplasty doctors in your own area to consult with by visiting our patient website, lapiplasty.com. There is a prominent Find a Doctor button at the top of the homepage, searchable by your zip code. With all that out of the way, I'd like you to introduce tonight's surgeon speaker, Dr. Cito. Jordan Cito, DPM AACFAS, is a board-qualified foot and ankle surgeon with special interest in trauma and limb preservation. Following completion of his undergraduate studies at the University of Wisconsin-Superior, Dr. Cito completed his 4-year medical degree at Scholl College of Podiatric Medicine at Rosalind Franklin University in North Chicago, Illinois. After medical school, he completed an exhaustive 3 years residency with an added credential of reconstructive rear foot and ankle surgery at Legacy Health in Portland, Oregon. In addition, completed a 1-year fellowship in reconstructive foot, ankle, and limb preservation in the Department of Orthopedic Surgery at the University of Louisville. Dr. Cito treats a variety of foot and ankle conditions, including but not limited to bunions and hammer toes, bunionettes, arthritis, ligament and tendon injuries, fractures, sports injuries, Charcot neuropathy, flat feet, and high arches. Dr. Cito has training in minimally invasive surgery, arthroscopy, Ilazarov external fixation, deformity correction, total ankle arthroplasty, and revision surgery, amongst a plethora of other procedures. Dr. Cito is passionate about research and teaching evidence-based medicine. He regularly speaks at conferences and has authored novel techniques in foot and ankle trauma surgery. Dr. Cito continues to be active within the profession and is a member of American College of Foot and Ankle Surgeons, American Podiatric Medical Association, and American Society of Podiatric Surgeons. We appreciate Dr. Cito volunteering his time tonight with us. I will return to moderate a question-answer segment at the end, and now for Dr. Cito.
Awesome, thank you for that, Kendall. So yeah, I'm Dr. Cito. I hail from Arizona. I spent a lot of my earlier career in colder climates, so now it's time for me to enjoy some warmer weather out here. So I'm really enjoying it. So the Lapiplasty system. These are the first couple of slides. I'm just gonna read through them, just some bookkeeping. So the Lapiplasty system was FDA cleared since 2015. It is not an investigational device. It is a patented procedure. It is manufactured by Treece Medical Concepts. It requires advanced training not offered by all the surgeons. Until today, there's been over 100,000 patients that have been treated. It is covered by most insurances. Medicare costs and coverages vary. You have to check with your provider regarding that. And find trained surgeons at www.lapiplasty.com. Now, with any surgery, this isn't just exclusive to the Lapiplasty procedure, but with any surgery, there's a risk of infection or adverse reactions to a foreign body. There can be pain, discomfort, or abnormal sensations due to presence of the implant. There can be loosening, bending, cracking, or fracture of the components, or loss of fixations. There can be migrations of the implants, loosening of the implant. We call these implant failures. There can be a delayed correction in the alignment. And oftentimes if you have decreased bone density, there can be some stress shielding involved, and also bursitis. So with that being said, what is a bunion? I think that's why most of you are here today to listen to this webinar. It's more than just a bump. That's the first thing that I think, a lot of patients I see in my clinic, I tell them this is not a growth of a bone. It can't just be shaved off. Historically, we used to do that in the past, and the results were not so good. I think in the beginning, patients would do well because we shaved off some bone, but again, we're not actually addressing the root cause of the bunion, which we now know after over a decade of research. The root cause of these bunions is an unstable joint in your midfoot, and that's the second arrow that you can see there. It's that joint. We call that the tarsometatarsal joint, or the TMT for short, but a lot of the deformity is occurring at this joint, and if we don't address that joint, we don't address the bunion. So typical symptoms include pain, swelling, pressure, numbness, and it can be worse as toes are crowded, and if you're wearing shoes that are ill-fitting, it can be painful. And oftentimes that can exacerbate or make a bunion a little bit worse or progress quicker. In reality, like I said before, there's been a lot of research that have been devoted to bunions mostly over the last 10 to 15 years. It is caused by an unstable joint in the middle of the foot, which essentially permits the bone to drift out of alignment. We call that a malalignment. And that causes this deviation of the bone, which results in this bump that we clinically see as a patient. And so even though footwear or standing for long periods can cause pain, a lot of the bunions are most likely caused by some sort of genetic predisposition or a biomechanical imbalance. And so, at least in my practice, in patients with flat feet, they tend to be more predisposed to certain bunions. And, it's those patients that, we also not only have to treat a bunion, but we may also have to treat the flat foot at the same time. So these can also be kind of convoluted. So bunions are complex deformities. So of course, it's important to, make sure that you consult the surgeon so they can kind of tell you about all these things. And this is a slide where I'm going to, at least I think, talk a little bit more. So the whole traditional 2D osteotomy surgeries, these, as of today, I think there has been documented over 120 different 2D bunion surgeries. And it was commonly used. I haven't done one since residency because I saw the recurrence rates, and a lot of the recurrent bunions that I see in my current clinical practice are a result of a previous 2D bunion procedure that was done and it recurred. The most common bunion procedure, 2D bunion procedure that a lot of us as before and earlier on in our careers, we have now shown at 7 years, there can be a 73% recurrence rate. That's wild. And so, and we know that, and this is my opinion, that conservative treatments with bunion spacers, toe spacers, pad splints, inserts, orthotics, now they may help alleviate some of the pain or the associated symptoms with the bunion, but they don't completely or definitively address the actual bunion. It's just essentially delaying what I consider the inevitable. And so what you can see is this crooked, and this is what the Leaning Tower of Pisa, right? And so with these historic 2D surgeries, what we would do is that we knew there was an unstable foundation, right? But yet we're just creating a bone cut, shifting over and stabilizing it with a screw. So we still have that unstable foundation. And the way I tell patients, it's like, if we're having cracks in the wall and we have an unstable foundation, we don't just repair those cracks, we have to address the foundation. Same thing with, if you have asymmetric wear in your tires, you're not just going to change your tires, you have to get a complete tune-up. You have to actually address the root cause. Why is this forming? And so again, I think over the last 10 years, we really started to understand the concept of bunions, and now the results are just incredible. And so what I like about this procedure, the Lapiplasty, is it's truly a system that's really streamlined. It makes it easy for surgeons to reduce a very complex deformity, hold that position, and then we put plates and screws on that unstable joint, and it's reproducible and it's predictable. those are the two words that, I love to say, because particularly with this procedure, it is reproducible and is predictable. As a surgeon, there's three things that I really look for when I do procedures. Number one, does it make sense? And this is a surgery that makes sense. Do you get good results? Yes, I get good results. And number three, again, is it reproducible and is predictable? That's the third time I'm going to say it, because again, it truly is a procedure and an instrumentation that works, and we get really good results. And we know now with midterm studies that the recurrent rates are under 5%. From 77% to 5%, I would say that's a huge shift in the right direction. Again, a lot of that is based on evidence-based medicine. A lot of research has gone on to this topic because a lot of people in this country have bunions. And so this is not like a new procedure. The Lapidus is essentially the procedure that's been around since the early 1900s. It got popularized in the early 1930s, but what's changed over the course of many, many years until now is that we made some modifications to the type of implants that we put in to stabilize this joint. And now we have very strong internal fixation, plates and screws. Sometimes we use staples, it just kind of depends on surgeon preference, but it's a lot stronger fixation. And with that being said, we can allow patients to weight bear earlier. And so Lapiplasty has really been in the forefront of bunion correction over the last 10 years. And again, results are very, very promising. So some common questions, we kind of will get these out of the way. So how do you determine if a patient is a good candidate for a Lapiplasty procedure? And so again, I think a lot of this has to take into account the consultation. So for me, it's, as a patient, does a patient have multiple medical problems? Are they diabetic? Do they have, high blood pressure? Again, a lot of these things, we try to optimize a patient prior to surgery, and it doesn't really matter if a patient has a mild bunion, a moderate bunion, a severe bunion. Did they have a previous bunion that now recurred? Really, any sort of bunion can be effectively treated and successfully treated with the Lapiplasty. And I kind of went into this third question, but can you get this Lapiplasty procedure if you had a previous bunion surgery? Absolutely. And so a lot of those previous archaic 2D bunion procedures, I have to do personally, a lot of my practice, a lot of revisional procedures secondary to recurrences. And again, I've treated those patients quite successfully with this particular system. And how is it different? Well, we now understand that these bunions, they occur in 3 different dimensions, and this Lapiplasty procedure effectively and efficiently addresses each dimension. And it doesn't just cut and shift the bone. We address the foundational problem, the root cause of why this patient has a bunion. And the good thing about this is the implants that we put in, they're very solid, and so we can confidently allow patients to go back to weight bearing a lot quicker than the older 2D osteotomies, because again, we're addressing the root cause and we have very stable implants. And this is another thing is, what may happen if I don't treat my bunion? So yeah, you might have a bunion, but you might not be in pain. And so this tends to be a progressive disorder. There's that hereditary component. It can get worse. The toes can kind of start to cross over. You can start developing contractures or deformities of the lesser toes. We call those hammer toes. And you can have pain on the ball of the foot. And so oftentimes when there's instability or there's an unstable nature of that joint that we're trying to address with the bunion, sometimes when we place weight on the ground with our foot, that column or that metatarsal bone doesn't get down to the ground. And so that pressure has to go elsewhere, so that goes to the ball of the foot. And patients very often, probably the most common thing that I see in my practice, they come in with pain in the ball of their foot. And so it's just one of those things where this may happen. It may not happen to everyone, but it's pretty common that this is a progressive disorder. These are just some clinical results. Again, individual results may vary, but these are procedures you can see 6 weeks out, 12 weeks out, and 6 months out. Left is before, right is prior, and you can see the correction really holds up. With longer term follow-up. And a lot of these procedures, you can see the incisions are a little bit longer, and now we can actually treat these bunions through much smaller incisions. So typically I'm using 1.5 to 2 centimeter incisions now, and we get the same result. And so we're just creating a smaller footprint, and yet getting good results with robust fixation. So it's just one of those things where if we can minimize our footprint, that can improve patient outcomes, less swelling, quicker recovery, and less pain. So this is probably the most common question that I get is, how long does it typically, what's a typical recovery timeline? And, there's a lot of factors that I think play a role in this, but I would say most often in my subset of patients, they're in a splint for 2 weeks. And usually they're non-weight bearing. For me, I still have an incision. Even though my incision is smaller, I want to protect the incision. I respect the soft tissues. And it also allows the swelling and everything to go down. And so definitely non-weight bearing, usually with the knee scooter for about 2 weeks. I see patients back at 2 weeks. They're out of the boot or a splint. I take sutures out and I send them to physical therapy. That's something that might be different from other surgeons. It's just something that I do is I send patients to therapy because for me, the therapist, what they can do nowadays is truly remarkable. They do compression pumps, they do dry needling. A lot of it is they can successfully reduce swelling, which is the main culprit of pain post-operatively. But also at 2 weeks, people are starting to put weight on it in a boot, and they may not want to put full weight on it. The good thing about physical therapy is I send patients to a pool. So aquatic therapy, I've been wildly successful with in getting patients to recover quicker. And so that goes on for about 4 weeks, and then at 6 weeks they're transitioned to regular shoes. That's pretty typical. And then 4 to 6 months, I would say, is pretty average for when most patients can resume most activities. I think in Arizona, patients are, the weather is obviously very nice here quite often. And so I'm usually seeing the 3 to 4 months because people are really, really wanting to get back quicker. And I think my biggest thing too is that physical therapy really helps with my patients to get back a little bit earlier. Again, it depends. If you might be a little bit older, you might have poor bone stock, you might be a little bit more careful, but I would say on average, it's about 3 to 4 months where I'm able to get patients back happy and resuming most of their pre-surgery activities. Insurance, is this covered by insurance? Yes. If this is deemed a medically necessary procedure, if you have pain, again, this is the tarsometatarsal joint, and so the codes that we use for the insurance companies is a specific CPT code, no matter if you're using the Lapiplasty or any other thing or any other system. But the main thing is that most patients who come in here, I have a surgery scheduler who does prior authorization. Medicare doesn't require prior authorization. Some insurers do, and so I have a team that kind of takes care of that before you even leave the office that day. And so, but yes, the procedure is definitely covered by insurance. And with that being said, are there any questions?
Thank you very much, Dr. Cito. We've had several questions come in this evening. Thank you for the great audience participation. We'll do our best to answer most, if not all, of the submitted questions now. If you haven't already, as a reminder, you may ask a question by clicking on the questions tab in your control bar and typing it into us. All right, let's get started. So a common question that has come through is, can a patient have both their feet corrected on the same day during the same time?
With me, no. Personally, I don't know any colleague or surgeon that does do both feet at the same time. I think a lot of it is just because we're trying to, have patients recover from one side and not two sides, and it just makes things far more challenging. Because naturally, if we do one side, patients will compensate to the other side, and so it can definitely impair healing. Historically, a lot of surgeons would do that, but patients weren't happy with that because, again, it's challenging to recover from two surgical sites versus one. So is there people that might possibly, I just don't know anyone. And I personally would not do both surgeries on both feet on the same day.
How much time would you recommend in between the surgeries if a patient has bunions on both of their feet?
At minimum 3 months. I find that for me, patients are usually fully recovered back to resuming their normal activities. I want them to have one strong, fully healed foot before we move to the other foot.
Great, thank you. Another question that has come through this evening is, can you highlight the first 2 initial weeks post-operation and how that looks for a patient?
Yeah. The first 2 weeks, so yeah, for me, you're going to be in a splint. I use plaster, and so the first 2 weeks you're going to be non-weight bearing completely, and that is just because you have an incision. And for me, the incision needs to heal before I start putting weight on it or patients are stressing the incision, because I don't want to deal with any wound complications. And so it's a lot of it's just kind of R&R for the patient. You can still shower. We dispense cast bags, and so you can put the bag over the splint so you don't get it wet. But a lot of it is just kind of resting, elevation, controlling the swelling, and just recovering. The first 2 weeks is usually the hardest part of the whole operation. And then after that, once patients are able to be transitioned to a boot, things become a lot easier from a recovery standpoint.
Great, thank you. Another question that has come through is, if my feet currently do not hurt, but I have bunions, should I have this procedure done?
Yeah, that's always a dilemma, right? Because we do know this is a progressive deformity. It happens to progress, but at the same time, if you don't have pain, doing surgery might invoke pain. And so for me, it's hard to justify doing surgery on a non-painful foot. And then I know, for a day or 2 that the patient's going to have pain. But it's one of those situations where, my always saying is to my patients that come in with bunions, but they don't have pain, is, I let sleeping dogs lie, essentially. I see some horrible bunions and in some patients, and they're completely asymptomatic, and they may continue to be asymptomatic. So I treat every patient on an individual case-by-case basis. Just because you have a bunion does not necessarily mean that we need to treat it surgically. It's really dependent for me. My main indication for surgery is pain. If you don't have pain, I would, I'd probably lean more towards just treating it conservatively and monitoring it. And if you do develop pain, then we can have a surgical discussion.
Great, thank you. Another question that has come through is, will I need physical therapy after undergoing the Lapiplasty procedure?
Yes, I would say probably nearly all my patients receive formal physical therapy. I don't give, historically I would give patients like handouts, hey, do these exercises at home, but it really never made the patients accountable. I've realized when I gave them an actual referral and the physical therapy calls them, it makes them accountable, and they have an appointment and they go. And I can tell you one thing, it's really helped with my post-operative recovery and rehabilitation. I think a lot of reason why my patients get on their feet quicker is I do have to give some credit to physical therapy too. They really help with controlling swelling, and patients are stronger. They're not as deconditioned, because again, they're working with therapy sometimes 2-3 times a week, and they're happier. And again, my goal is for patient care at the end of the day. So if I can do anything on my end to improve that, I'm going to do it. And physical therapy has been one of those valuable tools.
Great, thank you. Another question that has come through is, I have a job that requires me to be on my feet all day. How soon could I return to work after undergoing the Lapiplasty procedure?
Another good question. So I still always encourage patients, no matter if you have even if you have a sedentary job or you can work from home or you have an office job, just take the first 2 weeks just to, recover and allow the swelling to go down. Because usually it's the first 2 weeks where if there is any pain, it's usually within that time frame. So I always just tell patients take a little mini vacation, allow your soft tissues to recover, just rest, allow biology to kind of do what it needs to do. And then in 2 weeks, once you remove the sutures, then we can kind of get you back into work. Now, if you have a more high demanding job, that's gonna change the on when you go back to work for sure.
Great, thank you. If I had a bunionectomy in the past, am I still an eligible candidate for this procedure?
Absolutely. And that's, what we kind of alluded to previously, with those prior 2D bunion procedures, we do know now at 7 years that a lot of these can be, you can have recurrence up to 73%. And I do see a lot of recurrences, and I do use this system to address that. And I've been quite successful at it. And I would say my last 5 have all been due to recurrent bunions because of a prior 2D bunion correction procedure. So absolutely, to answer that question, yes.
Great, thank you. Can a bunion be too severe for the Lapiplasty procedure to correct?
No, with this, and that's the beauty of this particular system, is that no matter what size bunion you have, mild, moderate, severe, the Lapiplasty provides us with a great tool to reduce any type of deformity and do it very successfully and reproducibly. So no.
Awesome. I know we kind of highlighted the recovery process a little bit, but how soon can a patient shower or go swimming or get wet after the Lapiplasty procedure?
So showering you can do essentially right away, as soon as you get home from, the hospital, as long as you have a cast bag. So all my patients, I always educate them on cast bags after surgery, which is a specifically designed bag that goes over a cast or splint, and it creates a seal at the top so no water gets in. In 2 weeks, I remove sutures, and I still wait an extra 2 weeks after that for patients to go into a pool or submerge their foot.
How soon will a patient be able to return to physical activities, including the gym or outdoor recreational sports?
So to the gym, if you're doing upper body and you're not doing any squats or any deadlifts or any of that stuff, I mean, you can go back, once you're, in a boot, and you can do, any inclines, anything with the upper body, chest, whatever it may be. And so it definitely depends, but higher impact stuff, if you're going to do squats and kind of weightlifting, using lower body, doing running, you are looking at the closer to the 3-month standpoint.
How soon would you recommend a patient to travel? This could include by car, plane, boat.
It's again one of those things where, I've had situations in the past where, patients had to leave the next day or two because they had like a family emergency. In those particular situations, what I'll do is I will give them aspirin to take, a baby aspirin morning and night, just because they are non-weight bearing. Even though the incidence of blood clots and midfoot surgery is extremely low, but it's just a step that I take to ensure that it never happens. And so I will give them a blood thinner for their, if they are traveling within the first 2 weeks. But after 2 weeks and you're putting partial weight on it, I worry less about that, and it's definitely okay without limitation to travel after the first 2 weeks.
Great, thank you. If a patient lives in a two-story home, do you recommend the first 2 weeks that they stay on the first floor, or how do you recommend they get up and down the stairs?
I do. I do recommend staying on the first floor for the first 2 weeks. Again, you're not weight bearing. And I've actually had one patient before fall trying to scoot up on her butt to the second level, and fortunately she didn't get injured, but she did get a little bruise. And so it's just one of those things to avoid any secondary problems or any damage to the surgical site or any other area of the body for that matter. It's just more of a safety thing for me. But after 2 weeks, when you start transitioning to boot and weight bearing, it's far more manageable for sure.
In your experience, would you recommend that for the first 2 weeks, a patient have someone come and check on them or stay with them after the surgery?
Yeah, again, I think there's a couple different things that kind of play a role. Depends on, the patient age. I think a lot of my younger patients, and I've done done the surgery in 20-year-olds and also 70-year-olds. I think the younger patients, it may not be as important versus the older patients that might need a little bit more care. I wouldn't say it's absolutely necessary, but again, if you have a multi-level home, or if you have a big home, or you have limited space and there's a lot of corners, I think maybe potentially having that person for the first 2 weeks might make things a little bit more manageable.
Great, thank you. A couple other questions regarding health have come in. So if a patient is a diabetic, can they have this procedure done?
Absolutely, yeah. I've done this procedure now a few times on diabetic patients. It just, depends on are they optimized, and so are they actively working with either an endocrinologist, a primary care provider to ensure that their glycemic control is optimized. What is the patient's hemoglobin A1C? If I don't do elective surgery unless their hemoglobin A1C is 7 or below. Again, the reason why I do that is because it ensures that it reduces any risk of post-operative wound complications or infections. Another thing that I do is I get what a test that kind of looks at the patient's circulation preoperatively. It's called an ABI. If those results are normal, then we can proceed as well if your hemoglobin A1C is normal. And so for sure, we can get the surgery done if you're diabetic. It just depends on if it's optimized or not.
Another question that has come through is if a patient has arthritis, can they still have the procedure done?
Yeah, and it definitely depends on where the arthritis is in the foot. But it's one of the indications for this procedure. If you have arthritis of the unstable joint, which we're correcting, then absolutely we can do it. And we can do it if you have arthritis of the big toe joint as well. It just might require an additional procedure, maybe more preoperative workup, but that's why, a consultation with someone who's trained in the system is appropriate, because we can get x-rays and we can kind of, get more advanced imaging if required, to kind of get more insight into the arthritis and kind of next steps in management.
Another question that has come through is if a patient is currently taking a weight loss drug, do they need to stop taking the drug to have the procedure done, or can they still take it and undergo the Lapiplasty procedure?
So yeah, I would say the most common weight loss drug that I'm kind of seeing now is Ozempic, but there's a lot of others now in the market, and I can't even keep track of anymore. I know the hospital system that I do surgery in, anesthesia specifically requires patients to not take it 1 week prior to surgery. I believe it has to do something with an increased risk of possible aspiration. And so from an anesthesia standpoint, you have to stop taking those type of medications 1 week prior to surgery.
Great, thank you. I know we talked about this a little bit in the beginning, but we've had a few other people sign on a little bit later. Can you go back over what the recovery timeline looks like for a patient post operation?
Absolutely, yeah. So so the first 2 weeks are non-weight bearing in a splint. And then after 2 weeks, I see patients in clinic, we get x-rays, remove sutures, we transition you to a boot, you begin progressive weight bearing in the boot with physical therapy. At that time, you're also doing some aquatic therapy and kind of doing some general strength conditioning, mainly just to get swelling down. And then usually at 6 weeks, patients are coming back into my clinic, reevaluating, getting new x-rays again, and then we're transitioning them to regular shoes at that time. So I tell patients, at your 6-week follow-up, bring your regular shoes, and I want to see you get in your shoes. At that point, with physical therapy, the swelling is essentially resolved at that point. I've had really good success with that. And then usually at 6 weeks, again, you're in regular shoes, you start kind of progressing into activity. You start doing kind of lighter resistant type stuff, kind of working your way up. And usually at 3 to 4 months, patients are kind of back doing what they want to do prior to the surgery. A lot of the higher impact things and a lot of what they were doing prior to the surgery. So I would say 3 to 4 months is that time when patients are going back doing what they want to do. And again, if we want to address the other side, it's usually 3 to 4 months when we're entertaining that.
Great, thank you. Regarding the Lapiplasty procedure hardware, does the hardware from the procedure ever need to be removed?
Very rarely, very rarely. Personally, in any of my patients, I have yet to remove any of the implants. But is there a chance? Yes, and that's with any surgery. If you put any implants in, there's always a possible chance that we may have to remove them. There's a lot of factors that kind of play a role, but I would say for the most part, overall, the implant removal rate is extremely low with this procedure. And a lot of it is because the implants that we use for this particular procedure are very low profile, and patients very rarely actually feel the implants. And I would say before, there might be a chance that we'd have to remove it because those implants were a little bit proud and patients could feel them. But with this particular procedure, I personally, in my patients, have not had to remove any yet.
Great, thank you. Another question that has just come through is, what is the implant made of, and will I get buzzed at the airport if I go through the metal detector?
Yeah, it's titanium. I feel like patients would tell me if the metal detector went off at the airport, because I do follow up with them so often, and that just seems like a story they would definitely let me know. But I haven't heard anything yet. I don't think that it goes off in the metal detector. I still tell patients, at least like enlighten the agents that you had surgery and you have implants. But again, I haven't heard of any metal detectors actually going off at the airport.
Great, thank you. Another question is, can you perform a Lapiplasty procedure to correct a hammer toe? And can that be done at the same time as your original surgery date?
So yeah, you can definitely perform the Lapiplasty. It's not for the hammer toe. The hammer toe is usually a consequence of a bunion, but those are two procedures that we very often do at the same time in the same surgical setting.
Great, thank you. Is there any way to correct the bunion without having to undergo surgery?
And so, yeah, I know we kind of talked about that a little bit on the slide. Personally, I do see a lot of patients that have attempted a lot of these bunion correctors, these little splints, toe spacers, and a lot of things, orthotics, inserts. The list kind of goes on, and they come into my clinic, and they spend thousands of dollars on these devices, and it's a progressive deformity. It's underlying bone and joint deformity, and it doesn't really address the bunion definitively. It happens to come back because once you take it off, the toe goes right back where it was. In theory, it sounds good, and I know there's a lot of infomercials and stuff on that, and probably some ads on the internet and things. But my experience, they don't work to definitively address the bunion long term. But it can temporarily help relieve pain if someone is not wanting to have surgery right away.
Do patients lose flexibility in their toes or feet after the procedure?
No, with this procedure, the joint that we're fusing is a joint that biomechanically is actually non-essential. And so when we fuse this joint, patients don't really lose any mobility. Actually, I always tell patients their function actually gets better because it effectively addresses the bunion. It may actually improve mobility because we're also restoring and realigning the big toe joint at the same time. And so, no, actually your motion may improve, to be honest with you.
Great, thank you. We've had a couple more join late, so can you please describe what you recommend a patient take post-operation to combat pain they may experience post-Lapiplasty?
Yeah, and that's the good thing about this procedure, and now that because Lapiplasty continues to evolve, and so I now do these procedures through much smaller incisions. I do send home on about 2 to 3 days of either Percocet or oxycodone.
Great, thank you. If I smoke, will that prohibit me from being a candidate for this procedure?
Yes and no. So, this is a patient, this is definitely a population base that I am, I definitely have an extensive discussion with preoperatively. And so for me, tobacco narrows the blood vessels. And so they can minimize, nutrients and blood to the surgical site. And it can actually impair bone healing. And we know this. And so I will do surgery on patients that smoke tobacco if they can stop tobacco 3 months prior to surgery. And I will get preoperative testing to showcase that. Because for me, at the end of the day, it's about patient care, and I want to try and optimize and maximize patient outcomes. And so, yes, if they're willing to stop 3 months before, and I will get testing preoperatively to get that done.
Another repeat question is, how much time in between each procedure do you recommend a patient wait if they have bunion pain on both of their feet?
I would say at minimum for me, it's about 3 months, and that just ensures me that the other side that is surgery on is recovered and they're doing their regular activities again, and they can rely on that side, after we do surgery on the other side.
Will I be able to return to my favorite form of shoes regarding my high heels or my boots?
As definitely a podiatrist who does these procedures, I never encourage patients to wear high heels, but again, we're not fusing the big toe joint, so patients can still go back to wearing their standard shoes that they were wearing prior to surgery.
Great, thank you. Can you comment on a patient who may have osteoarthritis? Can this person still undergo the osteotomy?
Yeah, so osteoarthritis, they definitely can. It's just a form, it's just essentially joint space narrowing and painful motion secondary to diminished cartilage. That's essentially what osteoarthritis is. And again, that's one of the indications. If that osteoarthritis is at that first tarsal metatarsal joint, that unstable joint that we alluded to earlier in the PowerPoint, we can absolutely do it at that level. And if it's at another joint, again, that comes to, x-rays and the preoperative workup. Those are situations where we can still do the Lapiplasty, but we may have to address those other joints as well, just depending on, the extent of pain that the patient is in. But osteoarthritis is definitely another indication for this particular procedure.
Thank you, Dr. Sisto. Can you please describe the procedure in more detail? What exactly you will be doing when the patient is undergoing the Lapiplasty procedure?
Yeah, so kind of very briefly, we make a small incision at the level of the unstable joint. We put that clamp on, which you saw in the PowerPoint, that helps realign everything. It helps shift the bones where they need to be. We're doing this all under what we like to call fluoroscopy, which is just an x-ray in surgery. Once our alignment is satisfactory, then we make bone cuts. We compress the bones together. And then that's when at the time we placed either plates or screws or staples to hold that new reduction. And oftentimes the surgery itself can last anywhere from 30 minutes to 45 minutes pretty predictably.
What type of anesthesia is used for the procedure?
Definitely general. Anything less, the patients have the capacity to move a little bit. And so with this, in order to ensure we get a proper outcome and a good reduction, and to ensure the patient isn't fighting us, patients are definitely undergoing general anesthesia for this particular procedure.
Is there an age limit for this type of procedure?
No, I mean, it's, I guess I've done this in patients who were in their 20s. I've done this in patients who were in their high 70s. I guess the older you are, is there a higher chance or degree of not healing because of bone stock? Absolutely. But again, a lot of that is, we try to optimize patients the best that we can preoperatively. So if someone comes in with poor bone stock or osteoporosis, we get a DEXA scan. I make sure that the patient is being actively managed by a primary care provider or rheumatologist. And I will put these patients on, if they're already taking vitamin D, I will make sure they're taking 5,000 units every day, and we're going to double it on the weekend with calcium. to just optimize their chance at a full recovery and a successful surgery. And sometimes too, we can actually take autograft, which is graft from your own body, which contains a lot of stem cells that we place into the surgical site too, to help increase your chance of healing too. So there's a lot of things we can do on the surgical aspect to improve patient outcomes in patients who are a little bit older. So for me, I wouldn't say there's an age limit, but we just might have to do a little bit more workup if you're a little bit older. That's it.
Got it. Thank you. We've got time for a couple more questions. A very prominent question this evening has been, is the Lapiplasty procedure covered by insurance?
Yes, the Lapiplasty procedure is covered by insurance. Again, you know, the Lapiplasty is essentially a evolution of the tarso-metatarsal joint arthrodesis, which is a specific code that we use and that we give the insurances. It's just one way that we employ this procedure. And so if you have pain and you have documentation that this is progressing and you can no longer wear shoes, and you failed all these other conservative treatments, insurances will pay for this procedure. And I have yet to ever have an insurance deny this procedure.
Great, thank you. How long will it take until I can walk on my feet without shoes?
Without shoes, I mean, because you're weight bearing essentially in a boot at 2 weeks, and then you're back in regular shoes at 6 weeks. You know, what I've found is that when patients are in therapy, once they transition to regular shoes, my therapists have been kind of allowing them to kind of weight bear without shoes kind of early on to kind of get some of those muscles inside the foot. We kind of call those intrinsic muscles to gain strength, and just part of like the recovery process. They're at least my little protocol that I have. And so you are walking without shoes within that period, anywhere from between 6 to 8 weeks. But to do it comfortably, you're still looking at that probably the 8 to 12 week point when you're comfortably walking without shoes.
Great, thank you. Going back to activities post-operation, how soon can I get my foot wet or swim, specifically do laps in a pool after undergoing the Lapiplasty procedure?
Yeah, so for me, it's usually 2 weeks after I remove sutures. And so that's a month after the procedure. The patients can confidently go into a pool and submerge their foot.
Great, thank you. If a patient is inquiring about more information, how do they go about scheduling a consultation?
Yeah, so you just go to lapiplasty.com, and I know on the top hand corner you can see find a surgeon locator. You can put in your zip code, you can put in your city, and you'll notice, and you can even do a radius, you know, within 25 miles, 50 miles, 100 miles, whatever you choose, and you'll have a bunch of people who are actually trained and have the knowledge with this procedure who will pop up on your screen. And so, you know, I always tell patients, you know, utilize these resources as your advantage. There's a bunch of people who are very well qualified to do the procedure, and you may not even know it. And so as long as you put in your zip code and find the surgeon who's convenient for you, that's probably the easiest way to do it.
Great, thank you. And my final question for you tonight is, if a patient, it's a repeat question, of course, if a patient is not in pain, do you recommend the patient to get the procedure done or to wait?
For me, like I said, it's a good question to answer again, just because, you know, I know there are people that might do it if you don't have pain, but for me, pain is the #1 reason why I do surgery. Like I said, I have patients who come in here for something completely unrelated, and they have a severe bunion, and they're completely asymptomatic. I'm not gonna do invoke pain on someone who initially had no pain. Just because you have a bunion does not mean you have pain. Just because it progresses doesn't mean it's going to progress into pain. Yeah, it may progress, but you may not have pain. And so for me personally, no, I will not do surgery on a patient without pain, because that's the main reason why we do surgery, is to, you know, reduce deformity and prevent pain.
Great, thank you, Dr. Cito. So as we begin to wrap up now, if your question did not get answered or you think of something later that you wish you'd ask, feel free to reach out to us. Our email address is patientinfo@treece.net. You can also learn more or find a local doctor by visiting our patient website, www.lapiplasty.com. Don't forget that as a follow-up, we will email all registrants an archived webinar link for reference. We hope you found the information presented tonight helpful. Dr. Sisto and I appreciate you joining us this evening. Everyone have a great rest of your evening.